I would like to now invite Dr. Peggy Brown, AO, the patron of the Australian BPD Foundation, to deliver the keynote address titled Uniting for Change. Dr. Peggy Brown, as probably a lot of you or most of you know, is a highly respected leader in mental health reform. The foundation is very grateful for her support as patron for many years. Dr. Peggy Brown.
Everybody, and thank you. And thank you very much, Rita and Ruth. That was incredibly powerful. And Ruth, I'm sorry your name's not on the program. You need to be there in highlights. So I just want to begin by acknowledging the traditional custodians of the lands on which we meet today, pay my respects to their elders, past, present and emerging, and extend that respect to all First Nations people here today. I'd also like to recognise those with lived and living experience of mental health challenges, particularly those with BPD, and I guess acknowledge and respect the contribution that you make, your courage, your willingness to share your stories, and the impact that it makes, both in terms of shaping our services and the way in which we go about our work. So thank you. And just building on what Rita said, acknowledging those who have lost loved ones to BPD as well. Now, I'm very pleased to be once again the patron of the BPD Foundation. As some people may be aware, I sat on the Royal Commission for Defence and Veterans Suicide for just over 3 years, up until it concluded in September last year. And as one of the aspects of being a Royal Commissioner, you're asked to give up your other responsibilities and just focus solely on the work that you're doing. And so I had been in the role of patron prior to taking on the Royal Commission. And then when it finished, Rita and Norman approached me, and I was very pleased to accept their invitation to return to the role. It's a very small thing from my part, that a way of giving back and recognising the important work that you do. My husband said to me, "Why don't you just retire?" But there's just too much to do to do that. So what we're here today to talk about, I want to talk about, is just BPD. And I know I'm probably talking to people who know more about it than me, but I did just want to kind of set the scene for a call to action. As you all know, the symptoms of BPD, they do vary from one individual to the next, but characterised by symptoms of emotional distress, sense of instability and that sense of self, impulsive behaviours, sometimes with self-harm, and difficulty relating to other people, interpersonal relationships, and the world around. And it impacts a lot of people. It's not a rare issue. And as has already been said, so often misunderstood. And of course, it's associated with a reduced life expectancy. And yes, as we've heard, 1 in 10 suicide deaths in the coroner's court is associated with symptoms that could be diagnosed as BPD or personality disorders. Not that they necessarily carry that diagnosis, but that they could have been had they actually accessed treatment and support. But of course, that reduced life expectancy isn't just due to suicide. It's due to other issues as well, because there are co-occurring mental and physical health disorders that contribute to that reduced life expectancy. But it is, BPD does have the highest risk of suicide of all mental health disorders. And of course, there's a higher rate of presentation at other services as well, like housing agencies, justice facilities, forensic mental health systems, and has it, as Rita so very clearly described, the stigma and discrimination as well. I think from just describing those small features that I have, you can see that this is not just a health issue. It's very much a public health and a social justice issue, and I think we need to keep that in mind when we're talking about then the call to action for change. But I mentioned stigma and discrimination, and I do just want to speak to that because stigma and discrimination is something, you know, Ruth said treatment for BPD is not easy. It's made all the more difficult because of the stigma and discrimination. And we should be able to remove that, the stigma and discrimination, but the impact of it is so significant. Of course, it impacts on people's health-seeking behaviour, and you know, they either delay getting assistance or don't seek it out at all. It can impact on outcomes because, one, you're not getting the treatment, or two, it may impact in terms of your adherence or ability to adhere to a treatment plan. When you face discrimination in employment, it impacts on your finances, it can impact on your social opportunities, and you know, things like being able to access housing, etc. So that, you know, social and economic disadvantages there. And then, of course, in addition to the emotional instability of BPD itself, the stigma adds a sense of shame, a sense of worthlessness, isolation, etc. So it impacts the mental health of individuals. And then, of course, there's the impact on family, kin and carers and supporters. They too experience a lot of emotional distress. Emotional distress, often physical and financial implications as well. Often live with a lot of anxiety. They are known to have a higher incidence of their own mental health conditions, and that's greater than carers of people with other mental health conditions. And of course, not surprisingly, when we talk about, you know, stigma and discrimination, shame, etc., they often hide it. So they're not seeking help necessarily either, or receiving it. And they often lack that support and the information that they need to be able to most effectively and appropriately support their loved one. And of course, there are so many misperceptions about BPD that we know, and Ruth described them. You know, that kind of sense that it's a character flaw, it's a personality flaw, that people are with BPD are manipulative.
Sorry, can I just interrupt?
Yeah.
There's a request, anyone, AVW 413, your car is apparently blocking someone's exit. Thank you. Thanks, Peggy.
Okay. We have the culprit at hand. Yes, as Ruth described, people with BPD are far too often seen as just being attention-seeking or being manipulative. And again, that sense that it's either difficult to treat or indeed untreatable. You know, BPD is a serious issue and it requires a serious response. And, oh, something's gone wrong there. There was supposed to be a bit on the side that says, but it is treatable. So I don't know what's happened to that. But of course, you know, and treatment in different forms. I mean, of course, there's the specialised psychological treatments that might be more on the behavioural end, more on the psychological end. Then there's the generalised treatments that sit in there, you know, good psychiatric management, for example. And in addition to clinical treatments, there's a range of other supports. And again, we've got a heading missing here. I'm not sure what's happened with my slides. But other supports that are required. You know, psychoeducation and just understanding. So helping the family to understand what BPD is, helping the individual themselves to recognise their own triggers, their own, you know, patterns. To actually have peer and community supports to have that sense of connection and validation and, address the isolation. To have a stable environment and structure in the day. Again, makes all the world of difference when you're trying to regulate mood and emotions and behaviours. To have relationship supports, to be able to connect well with family and others and interpersonal relationships. Holistic wellness, that sense of not just, good sleep, good exercise, good diet. The latest is don't drink soft drinks. But also, things like mindfulness can make a difference. And then having, when you need it, a crisis plan and crisis response or helplines. And then, of course, advocacy and help with navigating what are complex systems. So there's a whole range of things in addition to the clinical treatments that can make the world of difference to people with BPD and their families. And as has already been described, access is to treatment and support is fragmented. I mean, there's no doubt the system's under-resourced, and Tony's absolutely right, let's put some more funds into it. But even in terms of what's there, it's not equal, and Ruth has described this, it's a postcode lottery. There are evidence-based treatments available, and I'm sure we'll hear more of that, but they're not universally accessible. And if you live in a rural or remote area, or even if you're from a lower socioeconomic group, or a diverse population, if you're old, for example, it's harder to get access to the treatments. We heard the Assistant Minister, talking about the funds government's injecting, and a lot of it into youth, and that's terrific. But let's not just forget about everybody else as well. And of course, what is available is the emergency department and the inpatient ward, but we also know that that's not the solution. It's not really the answer. And again, as Ruth has already said, or Rita, I'm not sure who, often the individual is blamed when the system fails. And we look at the person, but don't actually look at what else around them isn't working, that leads them to be the one with the blame or the finger pointed at them. So we do need to act now. We do need to unite and come together to bring about change. It's a call to action. And Mother Teresa said, I can do things you can't, and you can do things I can't, but together we can do great things. And I think that's where we are today. There is a lot out there that we know, individuals, organisations who can do good things, but we need to come together to do great things. And so what is it that we want to see change in this call for action? Well, I just want to kind of take a little sidestep and ask you just to think about cancer services, or the experience of cancer and cancer services. Now, in any 12-month period, just under 2% of the population in Australia have cancer. So that statistic is, not necessarily that different to what we see for BPD. Of course, the course is different, and over a lifetime, about 43% of the population will actually experience a cancer of one sort or another. And cancer is actually responsible for about 3 in every 10 deaths in Australia. So it's, I'm not trying to say it's the same comparison as BPD. But what I think is really interesting is if you look at this graph, and it starts from the year 2000 and it goes forward to 2024. But what you see in the line at the top is actually the incidence rate of cancer. And over the last 2 decades, what we see is there is a slight increase in the incidence of cancer, despite all of the, the wonderful research and, the advancements. The incidence of cancer is actually increasing, but the bottom line is the mortality, and it's decreasing. And I think that is because there is so much effort put towards cancer. What we see are, public awareness campaigns, there's, preventative actions, there's screening services, there's early, a lot of effort and investment in early detection and diagnosis. There are a wealth of clinical services, clinical treatment, medical, allied health. There are care coordinators that are cancer specific in some cases. There are multidisciplinary teams that come together and they have, structured collaboration and shared decision making. There are clinical networks built around the country around different types of cancer. When it comes to that end of life, there are, funded palliative care services. There is a lot of support for families and carers. There are peak bodies well established, and there's a lot we know goes on in the research and academic world. Now, why do I raise that? Just because if you can imagine if we had even a tenth of that for BPD, what will we be looking for? We want, public awareness campaigns, awareness raising. We want to see early diagnosis and early detection. It makes the world of difference. We'd like to see those clinical treatment services being widely available across medical and allied health. We'd like to see, navigators or coordinators to help people actually access the treatment and support. Wouldn't it be wonderful if we had multidisciplinary teams across the country? I know we have them in some specific locations, but not across the country. Clinical networks, support services, just like you have for cancer services, support for families and carers. What if we actually funded our peak bodies well? And again, that investment in research and academia. So what is it that we need to do to try and get to that end point, to reach that target? Well, I think to address, the needs of people with BPD and particularly to address that alarming statistic of 1 in 10 suicide deaths, we need a whole range of things. And I'm not sure whether you can actually see what I've got there on the slide, but we need everyone to come together. And as Rita said, the consumers, the carers, the clinicians, but not just the clinicians, the service providers in the range of other support areas. We need the academics, we need the policy makers, and we need the funders to all come together to understand what the issue is, to understand the seriousness of it, and to work together on moving forward to address it. We need a shared vision, and we do have the National Consensus Statement. Maybe if we all come together, that might need to be further updated. We absolutely need to have that voice of Ruth and all the Ruths in the world, the lived and living experience, to be at the centre of the policy, of the planning, of the service delivery, of the evaluation efforts. We need to make sure that we've got that shared language and purpose, a unifying narrative. We need to leverage the evidence-based treatment models that exist and build on those. Maybe we need to have a national model of care that is, put forward in the National Consensus Statement. Maybe we should have a BPD Centre of Excellence in every jurisdiction. Maybe we need a national framework to support families and carers of people with BPD. A national training framework for the workforce. Again, we have the elements of that. The work's being done. We need the policies to align across departments, and we need the funding and the funding mechanisms to support that policy. And as I said, I'm aiming big. I actually don't want this to be confined to health. It's got to go to all the others: education, justice, police, housing. And we need to build coalitions and networks, and really importantly, combat the stigma and discrimination so that, we actually have inclusive practices, not exclusion. And we do have some of these tools, as I've been saying. We have the lived experience, wonderful resource. We have the national consensus statement. We have effective treatment models. We have a national training strategy that's been mapped out. What we lack particularly is coordination. We need to bring people together to actually take this forward and to foster those cross-departmental cross-departmental collaboration and build the narrative, because the facts themselves, speak for themselves. They are convincing. And I think we need to focus on the moral imperative, and I think the 1 in 10 gives us that platform. And you might sit there and say, well, she's dreaming, that we'll never get there. But I think, we do see changing models and that real change is possible. We see models of shared care between GPs and specialists with, protocols and structured management plans and, joint responsibility and communication supported by IT systems. And even, we've seen funding reforms that actually do support that type of collaboration. If we look at My Aged Care, it is trying to integrate health services with social supports and housing and financial assistance. The NDIS is trying to coordinate disability services and health providers and education. And, if we look at New South Wales and their suicide prevention bill, that is actually mandating a cross-departmental collaboration around the issue of suicide. So I don't think our call to action is beyond the realm of possibility. And what can we expect if we are able to actually transform the approach? Well, I think we will see a reduction in the suicide rate for people with BPD. We will see less presentations to the emergency department and less inpatient stays, which don't necessarily help a lot. We will see better access to more timely care. We will see an increased workforce and particularly in terms of their capacity, capability, and hopefully retention of the workforce. We'll have, hopefully, a national framework for accountability, and I think we will have less inequity across the system for First Nations people, for those in rural and remote areas. We will decrease the intergenerational trauma, and we will see decreased fragmentation of families. Now, all of those outcomes are worth fighting for, I believe. And the cost of inaction is dark. It's not a dollar cost per se, it's the darkness that pervades if we don't take action. So just to conclude, as I said, this is not just a health or a mental health issue, it's a human rights issue. And we have the evidence, we have the voices, and I think we have the momentum. You're all here today, and you all have drive and purpose. So what we need now is to unify and go forward. And as I said there, let's build a future where people with BPD are seen and supported and empowered to thrive. Thank you.
As a small token of appreciation from the BPD Foundation, this is for you. Thank you very much. Thank you very much. Thank you very much, Peggy, for that insightful presentation. I really loved your slides, and I took photos of some of them. And I think you've given such a nice overview and of the holistic treatment of BPD and what can be done here on.